a disclaimer is that I don't know the diagnosis for this case, and I would need the help from the experts if we can come to a possible conclusion. So this is an enigma of an unexplained decline in vision. I have a patient who presented, a 31-year-old male with no history of diabetes, hypertension, or no history of any substance abuse. I want to take you through his journey of eye complaints. So he had a history of headache that started in 2020, which lasted for about 1.5 years. This was then followed by binocular horizontal diplopia for 4 months and decrease in vision in both eyes, which was sudden and painless for 1 month. So by the end of 2021, when his eyes were affected, he went to a neurologist ophthalmologist where his MRI was done, and the MRI was suggestive of raised ICT, feature showing partial empty cella or increased perioptic CSF space, along with some nodules which are enhancing that suggested of TB, CNS involvement of tuberculosis in frontal and cerebellar lobes. He also underwent a contrast-enhanced CT which showed thrombosis of the superior sagittal sinus. So he was diagnosed with CVST with raised ICT and a CNS TB, for which he was treated for about a year. After a year, all his symptoms resolved, but 8 months following the stoppage of AKT, he again developed a decrease in vision, and this time his left eye vision, which was documented elsewhere, was counting fingers 5 meters. His right eye was 20/30 with a normal color vision with a pale disc, but his left eye had a total color deficiency with disc edema with no mention of RAPD. He presented to us a month later, and at this visit, his ophthal findings were that he had 20/30 vision in both the eyes with total color deficiency and a pale disc. During this 1 month period, he had not taken any treatment from elsewhere. The vision spontaneously resolved. It became normal. So this was his first visit to our hospital, following which 6 months later, his ocular condition remained status quo. However, a year after his second visit, he came to us with a complaint of decrease in the right eye vision. So from 20/30, his vision had dropped to 2200, and again, both the discs were pale, but there was no RAPD. His disc photograph is showing a pale disc with attenuated arterioles, and his visual field defects. So this slide is showing both the right eye defect, that is a recent one, and a year-old defect, which is showing increased concentric field defect, which is approaching the center, which is correlating with his decrease in vision in the right eye. His left eye field is also more approaching towards the center, and his visual field index and mean deviation scores are deteriorating. His RNFL thickness is deteriorating in both the eyes, and his MGCL is also showing worsening in both the eyes. So this case, then we thought we'll go do an MRI with MRV with contrast, which the radiologist claimed it to be a post-contrast enhancement of the optic nerve, which we did not think after carefully seeing the scans. The MRV also did not show any new venous sinus thrombosis. So we are stuck with this case as to what could the diagnosis be, because there is an ongoing loss of RNFL, MGCL, and the visual field defects are also increasing. So could it be an underlying CNS TB infection which is causing a low-grade raised ICT, causing the disc to change? Or I haven't seen a case of ethambutol toxicity coming so many months or years later after stopping AKT. How do we proceed with this case? Any inputs from the panelists?
So, obviously, when you have somebody who has taken ethambutol in the setting of TB, you always think of ethambutol as a culprit. However, my concern labeling this as ethambutol is that it is sort of waxing and waning.
Yes.
Vision went down dramatically, came up. Then the other eye went down and came up. So that's something which we would not expect in ethambutol toxicity.
Just one point before Dr. Asta or Dr. Basi takes in, that would you still think of raised pressures here as one, because optic atrophy is already set in, and to have edema and already an atrophic now sometimes could be a challenge. There is the threshold bar is raised now. So is the raised pressures which is causing kind of ischemia where the patient now has a central field defect which otherwise didn't have with CSVT already on the imaging?
No, the field is constricting. It's coming from periphery to the center. Yeah, I get your point that actually the damage occurs because of the action occurs right at the disc where there's a lot of crowding because of healthy axons. Once it's gone into atrophy, whether the damage is, progressively going on. I get your question. It still could be because of the raised pressure. But what is the diagnosis here? The patient was on AKT for 9 months. Despite the TB treatment, the disease is progressing.
So the
patient resolved after 1 year of AKT. This is the picture 1 year later after discontinuing the AKT.
And the disc edema is persisting. Yeah.
Disc edema is gone, the vision has dropped now.
The vision is dropping, it's coming back to normal, then it's again
The
dropping.
patient was worked up for atypical optic neuritis, other things, NMO?
No.
Because all those cases which we treated as tuberculous optic neuropathy in the past, which we labeled, they turned out to be later on to be NMO.
Okay.
And General, again, your point of this being theoretically absolutely possible, because you will not see disc edema because this disc has already become pale. However, again, how would you then explain vision going down and coming back without anything?
So one additional point, I think we neurologists are trained in one thing, to do first and then think what is occurring, because this is how most of the neurological diseases will behave. You'll get to know the diagnosis over time. So I think there are two questions in this case. One, what is the diagnosis? And two, what else can be done? So as far as what is the diagnosis, I feel that there was a red flag for tuberculosis from the beginning. CSVT does not occur that commonly in tuberculosis. So arterial infarcts occur. So TB vasculitis may occur, but it's not the venous infarcts. So in case we are having venous infarcts, it is likely to be a procoagulant state or a vasculitis-like picture. If it's a male patient, then you ought to think of neurobeches. So what I mean to say is that even though the patient was given ATT and the patient responded, we ought to remember that for CNS TB, the patients received dexamethasone, which is steroids. And many a times the response is to the steroid and not to the anti-tubercular therapy. So I wonder whether CSF was repeated in this patient. And I think, Dr. Janil, like you were pointing out that whether a CSF is necessary when you're held up with a situation where you think it's an increased ICP, whether you should do the microbiological assessment. I will stress that even a biochemistry assessment looking for the proteins is an equally important part. So I think in addition, in case the patient's not responding, a workup for vasculitis, CNS vasculitis, primary or secondary, could be thought of. If steroids patient is responding on steroids, good enough. Otherwise, in case we are getting an increased reading on OCT, ophthalmologists, you're the best people, I'm just taking cold to castle. But in case you can have some benefit with optic nerve sheath fenestration despite atrophy because our patient is worsening. So these are the two things.
Thank you.